Good morning, and thank you for joining us here on the Morning Medical Update. I'm Jessica Lovell. It is summer, and just like many of you, we are working hard to bring you some fun and exciting shows come fall. This morning, we are bringing you a rebroadcast of one of our favorite shows. If you have any questions, please leave them below. We will answer them during our live broadcasts on Monday, Wednesdays, and Fridays. So sit back and enjoy this Best of Morning Medical Update.
Hey, good morning. This is Dr. Stephen W. Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dulles Simons Family Broadcast Studio. Delighted to be back with you on this beautiful, cool, crisp Wednesday morning. Welcome to Open Mics with Dr. Stites. You can find me here every Wednesday talking about all things COVID as well as other topics, including giving you a weather forecast. But today and for the near future, we are focusing on COVID-19. Joining me today virtually is Dr. Greg Poland, who's been with us several times during the pandemic. He is the director of Mayo Clinic's Vaccine Research Group. He's a nationally known, internationally known individual with research in this field. We will visit with him shortly. Dr. Dana Hawkinson, Director of Infection Prevention and Control, will join us shortly after with a look at today's COVID patient numbers. He's going to be dropping off his kids, I think, at school. First, let's see if we have any reporters on the line with questions this morning. All right, I'm not hearing any. You do?
I do
Go
have
ahead,
one.
Jill.
Hey.
Go for it.
How are you? Good morning.
Good morning.
Donna Pittman from Channel 9 has a question, and it fits right in with our guest as well. She wants to know about the COVID-19 variant called MU. Has it been here? What's the likelihood that it will be here? Is it a matter of time? How worried should we be about the initial reports that the MU variant is resistant to the current vaccine?
Okay, I just have to say, first off, we have got to rename this virus because I'm a MU graduate, and they're being called, now I'm being called a variant all the time, right? Let's either refer to, I don't know, we got to call it, maybe we'll call it a ZU graduate. But, you know, MU graduate, I don't know about that. Let's introduce Dr. Poland because have him join our conversation. My reading about the MU variant is that maybe it's resistant, but other variants appear the same way, but more than likely still going to respond to the vaccinations. Dr. Poland, what are your thoughts about the MU variant?
Yeah, Michael, I think you're right about that. It's worrisome, as many variants are, as you pointed out, because it does contain mutations that have been associated with mild to moderate escape of both vaccine and previous infection-induced immunity. Whether this will be or has any capability of outcompeting Delta and becoming a problem is unknown. What is a little worrisome is we started off with a few infections. We now know of over 2,000 infections in the U.S. Across 41 states. I think it's now in 49 countries. So it's one of those things, and we can't really explain it. We did see this with Delta, where it kind of stutters along for a few months and then an exponential rise. So will this happen with Mu? We don't know.
So, Dr. Poland, explain to us a little bit, and to our audience, and we talk about this on this program routinely, but I think you're so much better versed to discuss it a little bit. Why does this virus have to vary so much? Why does it keep changing, and why does it always feel like it's changing into something that could be potentially deadlier?
Yeah. So here's what our understanding is, and it's an incomplete understanding, particularly because this is the first time, I would say, Michael, that we're really watching viral evolution in real time, in the compacted time frame of just 18 months or so. So the coronavirus, SARS-CoV-2, is what's called an RNA virus. And the nature of RNA versus DNA viruses is that they don't have good, what's called proofreading ability. It's a little bit like copying a book. You and I have eyes and we see what we're writing, and that gives us proofreading, and we can make a correction. But imagine if we put a blindfold over your eyes and dictated to you and asked you to just write it out. You would, over the course of making many, many, many copies of that book, you would begin to introduce errors. And that's what happens when these viruses are allowed to be transmitted from person to person in the context of tens to hundreds of millions of infections. So that's one way in which they vary. They literally make mutations or errors in copying themselves. The other way that viruses can make major changes is through what's called recombination. This is where somebody gets infected with two variants or different SARS-CoV-2 viruses, and those viruses exchange genetic material. So we've seen both happen. Both will continue to happen over time. Now, why do they seem to be getting worse and worse? They're not really in one sense. What happens, just like influenza, is that new variants are constantly arising. The vast majority of them are not genetically fit, meaning that they are just going to die out. They cannot compete against the ancestral virus. So the only ones that, you know, the lay press ever hears about are those rare ones that actually mutate to become something important. And the reason that happens is there's a kind of mutational pressure applied to the virus. And what I mean by that is the virus, of course, may try to infect me where I have vaccine-induced immunity, or maybe somebody who's previously been infected and has immunity or some level of antibody against that. What the virus wants to do is to continue to transmit, to infect people. So it will learn how to evade that vaccine or previous infection-induced immunity. And that's why we get these variants.
Yeah, you know, it's just it just feels so darn crazy that the SARS-CoV-2 would want to somehow kill its hosts, in which case it doesn't have anywhere to go. Hopefully we won't keep running into that dilemma as we look down the road. So what do you think about the vaccines? They've certainly been an amazing success in the face of the Delta variant. A little concern, we're seeing, like at KU, we have about 15% of our hospitalized patients are fully vaccinated, but only 1 to 2% of our deaths. Yeah. So that's your experience has been mirrored pretty much nationwide and even worldwide, and where vaccinations are occurring. So they're extremely effective against severe disease, against death, and even against hospitalization. When you get to moderate infection, mild infection, or asymptomatic infection, then we do see efficacy drop. The interesting thing is, why do some fully vaccinated people develop moderate to more severe disease to the point where they're hospitalized? I suspect a good deal of that is the interaction between a very contagious or transmissible virus, time since the last dose of vaccine, and genetic susceptibility or predisposition. This is a topic that my laboratory has done a lot of work on over the last 30 years or so. They're just some of us that carry certain immune response genes that don't respond as well as others. And in a sense, then we develop susceptibility. Yeah. You know, I look at our list of the deaths who are fully vaccinated, and it's very clear these people are just really immunocompromised. They have, you know, advanced cancer on chemotherapy, organ transplant on Susceptibility, program, drugs to suppress them, their immune system, et cetera. Even our hospitalized vaccinated patients feel different to me than those who are unvaccinated. And, you know, they're a little older. They're not quite as healthy. And I don't know if that's something you're seeing as well.
Again, very much mirrors our own experience, is to the extent that we see vaccinated people getting disease sufficient enough to land them in the hospital. They are indeed either immunocompromised, older, frail, or have accumulated a lot of medical problems. And diabetes is a common one, or obesity, or smoking. those sorts of things. So it's not too unexpected. And in fact, Michael, it leads naturally to a discussion you may or may not want to get into about booster doses. And,
oh yeah,
and who
we're headed there.
But definitely, we are not seeing, for example, and I don't want to jinx anything, but we're not seeing people like you and me in the hospital after getting fully vaccinated.
Right. Well, what's interesting to me is that before, in the original wave, back last November that was so severe, in November, December, January, we had so many nursing home patients in this hospital. But now, even though some of these patients are 6 or 8 months from vaccination, we're not seeing a deluge of nursing home patients. So to me, that's one of the litmus tests of the success of vaccination. If it can work in a nursing home, skilled nursing population, well, it's going to work in you and I too.
Yeah, it's interesting where some studies have done, and, by definition, the vast majority of people in a nursing home are compromised in some way, else they wouldn't be there. And they'll go through and do sero surveys and find that there's been an outbreak in that nursing home. And there'll be a proportion of those nursing home residents who have serologic evidence of having been infected, but no evident symptoms, and certainly did not get sick enough to bring them to medical attention. So vaccines work, and they work well.
They do work. So, all right, so they work so darn well. When are we going to get the FDA approval for Moderna's vaccine?
Yeah, that's a great question. This is a function of time. So Pfizer was, of course, the first out of the gate, and they have gotten their BLA or biologics license application approved. So they are fully approved for people above the age of 12. The issue then for Moderna is they started their studies later than Pfizer, so they will follow Pfizer. Johnson & Johnson started even later than that, and Novavax even later than that. So we're going to see these kind of stutter across FDA's radar over the next many months in terms of approval. What I think is interesting is that for children age 5, is it 5? I think it's 5 or 6, up to age 12. I think that EUA is going to be coming probably by the end of this month. And that will be a great thing in terms of school.
That'd be great. Yeah. So if you had, because I know that if you listen to This Week in Virology or any of these other things, there's this story, the thoughts out there that the Moderna vaccine appears to have a higher level of antibody titers further out than Pfizer and more sustainable. Do you think that's relevant? Do you think that's something we should be paying attention to? Is Moderna the best? I mean, do you have a choice of vaccines?
Yeah, not really a choice. And if I did, I'd get in trouble. But
I wondered about that.
I think what the studies have arguably shown is that the antibody level with Moderna vaccine is higher. I suspect that that's due to at least 2 factors. It's not probably that it's a, quote, better vaccine, but remember that with Moderna, we're giving 100 micrograms, whereas with Pfizer, we're giving 30 micrograms, so a third the dose, essentially. The other thing is that time matters, particularly in vaccines. The longer the interval between doses, the higher the antibody level. The only exception to that ever seen has been with the shingles vaccine. So Pfizer's given in a 3-week interval, Moderna in a 4-week interval. Sounds like that's a trivial difference, but in vaccinology, that's actually an important difference. On the other hand, the longer you wait, the tension is the longer before you're fully protected. So each company studied different time intervals. Pfizer 3 weeks, Moderna 4 weeks. And I think that's probably those 2 factors are the difference in antibody level.
Yeah, I wondered about that dose and also the time. And you think J&J is going to end up with a second dose?
I do. They, in fact, have done their what's called their ensemble study, where they have studied a second dose. I think it's probably inevitable that over time it will happen that we will likely require booster doses, meaning a third dose if you got an mRNA vaccine and a second dose if you got the J&J vaccine. Having said that, there's a lot of controversy over booster doses. I think the White House kind of got ahead of itself in their appropriate desire to control this pandemic. And when we measure antibody levels, of course, we're forgetting about the other major arm of immunity, our cellular immunity, which is terribly important and highly likely to protect us against exactly what we're seeing, moderate, severe disease or disease that causes death.
Yeah, I think that's right, and so one would then say, "Gosh, should everybody go get a booster?" And I know that's a subject we probably ought to hit. It's kind of like the who, what, when, where of vaccinology. I love the turn of phrase. So, what is the who, what, when, where of vaccinology regarding boosters?
So, I think the recommendation for people who were immunocompromised to get what's formally called a late additional dose, it's still a third dose, was appropriate. In other words, a full series for an immunocompromised person with an mRNA vaccine is 3 doses. Well, what about people who are not immunocompromised? I think the next logical step will be a booster for people of a certain age. What that will be, we have not yet fully seen the data, but it might be 50, 60, 65, something like that. Therefore, I fit into that category. But that remains to be seen, whether we'll get a booster dose or require booster dose. Then you kind of march that down and say, at what age do people need a booster dose? And in Israel, I think they're down now to age 30. Again, I think the evidence for that is very, very scant. And it's very hard to separate out. Is the breakthrough infection rate we're seeing due to the fact that we are dealing with a much different variant than the one the vaccine was developed against? So is it variant? Is it time since last dose? Is it both? And there's hints in the data that both factors are important. As you and I know, all of us listening have been infected one or more times with one or more of the 4 seasonal coronaviruses. And the reason that happens is that we do seem to lose immunity over time and can get reinfected with those seasonal coronaviruses. No reason that mechanism wouldn't also be operative with SARS-CoV-2. So I suspect the reason this is hard to tease apart is that we're dealing with 2 interacting factors, new variants and time elapsing.
Yeah, that totally makes sense. So Hawkeye just came into the studio. Hawk, welcome aboard.
Hi.
All right, Dana
Hey,
Hawkeye,
Dana,
our
how are
medical
you?
director. There you
Good
go.
to see you. Thank you.
I told him that we have to change the name of the Mu variant because there's my graduation certificate from Mizzou, Stephen W. Stites.
Yep.
Mu variant. I don't get it. It can't be Mu variant up there. No, it's got to say Mizzou, something different. All right, so Hawkeye, how are our numbers today?
Numbers are holding steady. Right now we're down into the mid-50s. We kind of have been there. We have 55 active infections with 16 in the ICU, 9 of those on the ventilator, and 8 of 55 of those active infections are vaccinated. However, of our so that's a total of 15% of our fully vaccinated that are in the hospital. We still have 45 additional patients that are in that recovery period, so a total of 100. And then Hayes has 14 patients, 9 active and 5 in that recovery period as well.
Dr. Poland, last fall, we tried to figure out what caused that surge. And maybe society was more open, not as much masking, especially in some areas of the country, like the Midwest. But also schools were back in session. And you wonder if the schools and all the... But it took a number of months. It took like 6-8 weeks before we really felt that ripple effect moving down the chain. Is that going to be true of the Delta variant? And do you think we're going to actually see yet another wave come November, December?
Absent masking and vaccination, I think it is inevitable. And, we seem as a nation to have lost our capacity for critical reasoning and thinking. This has been an amazing and I think wrong-headed experiment in the midst of the worst pandemic that any of us have seen in our lifetimes, in the face of the most contagious variant we've ever seen. Let's ban masks and bring children together and crowd them in schools and see what happens. Well, I don't think there's any of us who study this that wouldn't have guessed that we knew exactly what was going to happen. In fact, last week, we had over 250,000 new infections in children. They composed 27% of new cases, a number far higher than anything we've seen with this virus in kids before. So there's no question that crowding them together and, now take wintertime when there'll be other respiratory viruses causing them to cough, sneeze, et cetera. I don't think there's any question that we're going to see a resurgence.
Yeah, and I'm concerned about it because I'm concerned about this intermix with, we're seeing a large number of RSV, obviously well reported, and we look at our own data, even in adults, we're seeing a lot of RSV hospitalized right now. I mean, a lot, and it's a little concerning. And then influenza coming on the scene, schools back in session. If kids aren't wearing masks, I just think, man, this fall we could be back in trouble again, and with the healthcare system already overburdened. And the answer is so darn simple, because we've proven it over and over again. If you just put a mask on and get vaccinated, we can avert this crisis. And I look down at South America, where it looks like their data, their numbers are way down, but their vaccination's up and they wear masks.
Yeah. I mean, you're absolutely right. It's so self-obvious and amazing. The way I've explained it to people is this. I'm going to be a little philosophical here.
Please.
But it has to do with a term called epistemology, or how one knows or discovers truth. So let's agree that SARS-CoV-2 is a scientific and medical problem, and therefore it deserves to be solved with medical and scientific evidence. But once you reject science as a way of knowing, then the only thing you can do is appeal to some other man-made structure, economic structure, political structure, or distortions in how man thinks about religion. And what has happened in our country is a conflation of politics, economics, and distorted religion as opposed to what Scripture actually says. And that has gotten people to think of a mask, which is a medical tool, as some sort of marker of authoritarianism or of political freedom or of economic bondage. And that's just wrong thinking. It's wrong epistemology. And it has cost us tremendously. We are now, in fact, I just looked up the numbers right before this show. Since January of 2020, okay, 1 out of every 490 Americans has died of COVID. 1 out of every 490. It's resulted in about 1.5 to 2 years decreased life expectancy in the U.S. overall. For African Americans, an even more severe effect. They've lost about 3 years of life expectancy. The last time that happened was in World War II. And what did we call it? A world war. And we prosecuted the war like it was a war. This is very, very different. To see how distorted people think, and this kind of amused me in one way. You might remember a few months ago, there was a report of a deadly type of snake that had escaped down in a city in Texas. No parent was letting their child outside to play. There was one snake, hadn't bitten anybody, but it's known to be poisonous, and kids were not allowed to go outside and play. In the face of this, causing 250,000 new infections in children last year. Last week. Over 1,000 schools have had to stop in-person learning and go back to distance learning. In the face of that, and 1 out of every 490 Americans dying, fortunately very rare in children, we act as if there is no pandemic. And that is just absurd by any lens you want to look through.
Yeah, I think we've conflated and created demigods out of people who say things that some want to hear.
Yeah.
So let's look a little bit back before we move to questions here in just a moment. But if we look back in history, anti-vaccination attitudes have some sort of, it's hard to say this, but predated vaccines itself, even back into the influenza crisis in 2018-19. Compare what we're seeing now with misinformation and hesitancy from the smallpox vaccine.
Yeah, well, in fact, I wrote a review article of this, about this in 2011 in the New England Journal of Medicine. And Stephen, you're exactly right. By the way, I think I've been calling you Michael because I have a friend, Michael Stites, who's a radiologist.
How'd you like? No, that's okay. How'd you like how I worked my diploma into the conversation to help?
Thank you. Thank you. We're even.
Nobody cares where my diploma says, frankly, but yeah, there you go.
But at any rate, just to give you an example, there was actually a famous minister in colonial New England that was pushing for smallpox vaccination. The anti-vaccinationists firebombed his house. So, as Solomon said, there's nothing new under the sun. There's always been a fraction of people who reject science as a way of knowing who are anti-vaccine. And then another group of people who are vaccine hesitant. They tend to be individuals who more often have legitimate questions. They have hesitation and need answers, and they can be persuaded once they have the data to get the vaccine. But in the context of a pandemic, when you have as large a number of people unvaccinated as we do in the U.S., you now cannot control the pandemic. In my view, some would disagree with me. We have given up our opportunity to eliminate this from the U.S.
Yeah, we have to control it now. I'm with you, because how do you eliminate something when it is so widespread in a community level and vaccinated people can spread it? And it can still mutate. So I think, gosh, we were so good in March, and then March became April, April became May. Vaccines didn't increase, and the Delta variant arrived. So it's an unfortunate tragedy as we look back over it.
We had politicians, basically pretending that the pandemic was over, masking mandates were lifted, and trying to get the public to understand we're not waffling. It is circumstances that have changed, and that's why we need to go back to masking.
Yes. Yeah, it's such a simple, and we say it here all the time. People, it confounds me. People say masks don't work, and you sit back and you look at hospitals where there is a COVID surge of every moment of every day, where patients are concentrated on wards. They all have COVID. They're all acute, and our staff don't get sick, right? Yeah. Why is that? Because masking works. It's just, so freaking obvious, and yet people still want to argue it and tell us it don't work. Okay, let's see what community questions are out there, Jill.
Hey, we've got some good ones this morning.
I bet we do.
Jan, yeah, she's a regular watcher. I'm going to start with her because it's a little bit of a math word problem. And she wants to know about the concept of cumulative exposure to the COVID-19 virus. She writes, the CDC recommends you quarantine if you have 15 minutes of cumulative exposure to the virus over 24 hours and are unvaccinated. She wants to know what happens at 36 hours. Can you help her?
Yeah, I think those are data that come from modeling. So they're models at a population level. I don't find them very helpful at the individual model. If I was infected with COVID and was symptomatic and stood in front of somebody unvaccinated, coughed in their face and walked away. So what is that interaction? A minute, 30 seconds? The odds would be very high that they would be infected. So there is nothing magic about 24 hours. There's nothing magic about 15 minutes versus 13 minutes versus 20 minutes. It's just a model at a population level. And I think it's confusing for people.
And do you think the Delta variant is truly more contagious? You know, I remember the thing that was somehow got leaked about the events in Massachusetts, where it appeared that that it only took 2 to 4 minutes of exposure with the Delta variant as opposed to 10 to 12 with the original or the Alpha variant. What's your thought about that?
What we can say is, compared to the ancestral Wuhan strain, even compared to the Alpha variant, that viral loads or viral titers are high. In fact, they're about 1,000 to 1,200% higher than they were with ancestral or even Alpha. That's one issue. We also know that the affinity of the virus for binding to its cellular receptor is much higher. So these pieces of data all fit together in a virus where infectivity or transmissibility has increased. In fact, some interesting data that I'll share with you. This came from a colleague of mine where they actually did the calculations, but they looked at let's take Alpha, where the reproductive number, the R naught, was maybe about 2.5. So if you took a completely susceptible population and you went through 10 cycles of transmission with a reproductive rate of 2.5, you end up with about 9,500 infections. Now let's increase that reproductive number closer to what Delta is, not 2.5, but about 6 or more. That same cycle of 10 transmissions doesn't give you 9,500 infections. It gives you 60 million new infections. And that's a term that we pay a lot of attention to in virology called exponentiality. And that's why we've seen the spread of Delta that we have, even compared to Alpha or Wuhan strain.
Yeah, that's a struggle, Hawkeye. You know, this exponentiality, you feel it, you know it's real when you see our numbers rise in our community.
Yeah, I mean, those words that he's talking are a struggle for me, for sure. But I think those are good points. You know, is it more transmissible? Just like Greg said, we know that there are changes in the spike protein that make it bind better to our human receptor cells. Is it 2 to 4 minutes? Who knows? We don't know what the infectious dose of virus is. It's probably on the scale of just a few hundred viral particles. But just as he said, if you're in the cough pathway of somebody that you're talking to, and we know that there are millions of viral particles in those respiratory droplets, the likelihood that you are going to be exposed to those and probably get infected is quite high. So I think the other things that we have to remember is that the coronavirus, SARS-CoV-2, is not all about the spike protein. We're also looking at other components of its genome. We know that the Alpha variant, for instance, causes reduced activity of interferon, which is one of our major early antiviral chemicals that our body secretes. So there are very many reasons, there are complex reasons for increased fit of the virus, increased transmissibility, if you will, but certainly what are the reasons that make it more fit? We are still really trying to learn those.
Yeah. All right, Jill.
We may have to get our freezer videos back out.
I think we do.
When you're singing.
I think we do. Dr. Poland, last year, Hawkeye and I went to a freezer and we said, okay, these are our breath clouds, and we demonstrated our breath cloud in a freezer video. And what happens to that breath cloud when you wear a mask? You know, obviously there is none. And then if you don't wear your mask, you just kind of have your mouth but not your nose covered. Well, there it is again. But it was pretty, you know, you can learn a lot from a deep freeze meat freezer.
That's a great idea.
Yeah, we showed it. We got it there. I think it's probably time to go back and remind everybody.
Right.
And something like that could go viral. Oh.
Yeah. Whoa. Okay, this is a dangerous combination right here. Here we go, because I'm going to start making Star Trek references now.
Yeah. Hey, so Kay writes, and she says, thank you, doctors, that this update has been a godsend to her. She said, my question is, when a person, she sounds like she's had COVID for 3 weeks and she's been really sick, not sick enough to go to the hospital, she's asking when might she, if she took a test, show that she's negative for COVID? And she asks if we test our inpatients after a time to make sure that they are negative for COVID.
Yeah, Hawk.
Yeah, certainly we do not go with the test-based strategy. The recommendation is that after you've had COVID or been diagnosed, there should be no reason that you need to test yourself again. We are really using that 10 days, and that's because the majority of the studies so far show that it's very difficult to isolate, especially infective virus, really after about those 10 days. So there really should be no reason to test once you're positive, and we'll see what Dr. Poland says as well.
Yeah, Dr. Poland, what do you think? 'Cause I've also heard that the Delta variant, you're not as infectious as long with the Delta variant as with the original Wuhan strain.
If you're vaccinated. So if you look at the Singapore multi-center study, which I think is among the better ones, while the initial viral titers in vaccinated but breakthrough infected and unvaccinated but infected people, while those titers were roughly equivalent, the viral titers in the vaccinated fell very quickly over just a few days, whereas with the unvaccinated but infected, it's this slow, gradual drop. And I would absolutely agree with Hawk. There is no reason to test the otherwise healthy person. We could argue about maybe immunocompromised individuals. And one of the reasons for that is, what does the test mean? Remember that the test will tell us whether there's genetic material there. It does not, as Hawk was alluding to, it does not tell us whether there's infectious virus there. So what? That there's residual genetic material there. It's irrelevant.
You know what I love about this program is that it's clear that Hawkeye's name has changed from Dana Hawkinson to Hawk. Because if Dr. Poland calls you Hawk, I call you Hawk, our listening audience calls you Hawk, you're Hawk.
That's great. That's fine. I'll deal with that.
Okay.
But I would also like to say that, the reference that Greg brought up in that image is such a good figure in that paper. It really does show, and it shows how vaccination, what it does is boost your immune response, that memory immune response, so that your immune cells can be quickly gathered together and recruited to fight off a new infection. And that's exactly what that figure that he was talking about in that reference showed, is that after those few days, you can see in those vaccinated people where their immune response starts to take over and those viral titers start to go down.
Okay, so here's the most important question in the room. Enough of all this important science. Oh, okay, you got to make it. Go ahead, make the. Tell me, then we're going to talk about the most important question. Go ahead, Dr. Poland.
I was just going to say, my lab just submitted a paper where we had looked at a group of young, otherwise healthy people, demonstrated that antibody titers sort of waned over the 3 to 6 months, but memory B cell pools increased in size, exactly getting at what Hawk was saying. This cellular immunity component is real, it's important, and significant in terms of dealing with infection.
Okay, so here's my most important question. So I'm going to borrow from the Lollapalooza data that makes me feel a little better about this. I want to go to the Chiefs game on Sunday, right? 75,000 people clad in red at Arrowhead Stadium. Mahomes walks on the field. It's just a moment in history. You just got to be there. All outside, I'm vaccinated. Am I safe? And of course, in this case, I'm talking to 75,000 Chiefs fans.
Yeah, so I'm going to really get you, and I noticed you turned to me for that.
I did, because I figure you're a Vikings
fan. This is the most important question of the day, right?
That's it. You guys are going to be dressed in purple.
I would say if you're playing the Vikings, don't even bother to go. No, my serious answer, and I think we could have legitimate disagreement here, but my serious answer is, in a crowded outdoor venue like a football stadium packed with, I don't know what, 70,000 fans
75,
or something.
yeah.
I personally would wear a mask. I know others might not, because outdoors has been shown to be safer than indoors. I will point out that there are now counties and states that are mandating masks even outdoors, where there are variable numbers of people. 2 counties in the state of Washington have said outdoor events that have more than 500 people, masks are mandatory. And I might say that Dr. Fauci also commented that, how did he put it? Going to a packed football stadium was not smart.
Yeah, I was planning a mask, actually.
Yeah.
It is interesting. And then you look at some of the information from Lollapalooza and others, and you're like, I'm surprised there isn't more spread in some of those events.
Yeah.
But then I see these.
This is really interesting to me. Why are some events super spreading events and others aren't? It likely is a complex equation of who's there, how interactions and movement are occurring, vapor pressure, temperature, and humidity. You look at Sturgis, and some of those numbers are just coming out.
And they're not
Sturgis
good.
has had a major effect each of the last 2 years on increasing numbers of infections. Lollapalooza, they were not able to demonstrate when that had like 20,000 people, something like that. Other athletic events like high school football games have been shown to lead to spread. So it's quite variable.
It's hard to understand.
Yeah, and I think our audience wants a single black and white answer, and there is a lot of gray, and I think it's multiple combinations. We have heard that 10 to 20% of people infected with SARS-CoV-2 do 80% or more of the spread. It's also, look at Sturgis. It was multi-day rallies, and it wasn't just outside. It was indoors in the evenings at night. So I think there are differences, just as Greg had talked about, between Lollapalooza, between some of these other things too. It is really a granular thing, and it's difficult for a lot of people to understand, but there are shades of gray and significant details.
I'm hoping for a windy day, actually. I think that'll make it a little bit better, right? All right, Jill, other questions?
Yeah, so you doctors have answered 2 community questions so far, and we have about 24. So let's rock through some.
Well, we're having fun, though. It's a good time. Live long and prosper.
And it is interesting, but let's just see if we can get through a few, okay? Andy wants to know, are there any connections from increased allergies due to COVID shots? He got his COVID shot, never can remember allergies being this bad for him before.
No, I don't think so. Dr. Poland?
Not aware of any connection.
Okay.
All right. Jean wants to know, what about the idea of giving out rapid tests to parents of school-age kids to break the cycle of COVID spread?
Oh, God. Then we're going to let everybody interpret their own rapid test, Dr. Pullin, what it means and how they're going to respond. I don't know. Masking solves the problem. Masking solves the problem.
I've got an issue with that because the sensitivity and specificity of those assays are not optimal. Now, people have gotten around that by doing frequent rapid testing, but at this point, I don't think we're prepared for that.
And how you handle the test and whether or not which test you use, and then that's going to impact the parents' decision-making process. It's going to be really tough to figure all that out. But you know what we can figure out is that masking works. Again, we prove it every day in the hospital, every darn day.
Jean also points out and recognizes that our tests here in the United States are pretty expensive, $25 a pop, so I think for like 2. Sandy wants to know, do we need to have 80% of the whole world successfully vaccinated to stop the virus?
Oh, that's a great question. Okay, Dr. Poland.
Well, in the face of Delta, and this is due to human behavior, our herd immunity threshold is not 80%. It is probably 90 or more percent. That's one issue. The second issue is that masking, vaccination, and distancing, which internationally means control of borders, works. That's been demonstrated in multiple countries. In the context of a worldwide pandemic, it makes no sense. I realize there are economic implications, but it makes no sense to allow unvaccinated, untested people to travel in the country. You can't do that in other countries, and it's for scientific reasons.
Sean wants to know, what are your thoughts about super immunity for those who have been infected with COVID, recovered, and then got fully vaccinated? Is there such a thing?
Yeah, but let's not all go out and do it.
Yeah.
Bad strategy, you know.
Bad strategy. You don't need to be super immunized or you could do just fine if you just get vaccinated and wear a mask. Otherwise, the problem is that you do run the risk of death and dismemberment and post-COVID syndrome and long-haul syndrome. I mean, what a bad strategy.
It's a little bit, to use an analogy, when you drive your car, do you get dressed up in a fire suit and wear a helmet the way you would if you were a race car driver? No. I mean, good enough is good enough. Let's do the things that are good enough before we worry about the things that, solve the 0.001% of the problem.
Deb wants to know, if you've had your first Pfizer, should you wait 4 weeks instead of 3?
Ooh, good question. Follow up, Dr. Poland.
So, Pfizer is 3 weeks because that's what they studied, and therefore that's the only thing they could be approved for. What we know in vaccinology is that increasing the interval between doses, with the one exception of the Shingrix vaccine, there is no other known exception, increasing the interval leads to better immunity. The tension in there is the longer you wait to get your second dose, the longer you remain susceptible. So at this point, my recommendation would be, don't worry about, should I fiddle with a week or 2 here? Worry about getting vaccinated. Worry about getting fully vaccinated and wearing a mask. I'm going to keep repeating that because, and if there was a way for me to look at in the eye of every listener, and I will stake my integrity on this, my reputation, everything that science knows right now is, if you want to protect your life, your health, your well-being, and that of your family members and community and church and work members, wear a mask indoors and get fully vaccinated. It's safe and effective. Perfectly safe? No. Perfectly effective? No. Nothing that man makes is perfectly safe or perfectly effective. Extraordinarily safe and effective? Yes.
Yes.
Still a couple more?
Please.
All right. Melissa wants to know, what are your thoughts about the time it takes to get PCR test results back? She says it takes forever. She worries that that's going to be a discouragement to people getting tested, especially as we go into fall allergies.
Yeah, I think it really depends on where you go. Hawkeye, what, are we 24 hours now? 24 hours?
Or less,
Yeah, I don't know. I know some places that are pulling are really long, but to some degree you got to kind of figure out what their turnaround time is.
I think in the academic laboratories, they are 12, 24 hours. I think in some of the commercial laboratories, that's where you see longer wait times.
Yeah. I had a friend in Oklahoma that was tested. It took him 6 days to get the results back. I don't know what you do with that. And here we can do it in 12 to 24 hours. And sometimes when the rapid PCR analyzer, it'll be 4 hours. So, it depends a little bit. You got to figure out where to choose your poison from.
And she also said that her antigen test came back really quickly. Is that something you can rely on?
Well, that's the rapid test again, and it all depends on how good the rapid test is, how well it was administered. If it's positive, it probably means something. If it's negative, I don't know what that means, Hawk.
Yeah, absolutely. I mean, I think that's the same thing we've been talking about. We know that the prevalence of the disease right now in the community is high, so there really probably is not that chance that you're going to get a false positive. But if you are symptomatic and testing for that reason, if it is a negative, we have asked you that you go and get a PCR to really confirm that negative.
Jeannie wants to know, do I have to get the same booster? If I got Pfizer, can I get a Moderna booster?
Dr. Poland.
So so-called mix and match studies are in progress. The official recommendation is to get whatever you got for your first dose. If you're asking me as a scientist, do I think there's any scientific reason that there wouldn't be benefit? No, I don't see any inherent scientific obstacle to developing immunity with a mix and match strategy.
Okay, just a couple of more.
All
Sharon and Brenda wants to know. Sharon's 97, Brenda is 65 years old with a lot of comorbidities. She wants to know, they both want to know, are we immune compromised? One is age, one has comorbidities.
It's hard to answer that question, but if you're asking the question and you're of an older age, I'm going to say probably. And at 95, I'd be a little concerned. And I think, Dr. Poland, those are two candidates who might be ripe for having that third shot. What do you think?
Yeah, I would agree. Yeah, I mean, 65 is not a reason, but 65 with medical problems of a certain nature. And because it can be hard to determine, my recommendation is talk to your healthcare provider who can help you determine, do you fit into that category and do you need a third or booster dose?
Yeah.
Last two questions. Cindy wants to know, is there any issue with breakthrough cases who get monoclonal antibodies?
I'm not sure the meaning of the question. I'm not sure about that,
yeah.
I guess maybe what they're getting at is after monoclonal antibodies, we generally wait 90 or more days before immunizing. In other words, the monoclonal antibody could interfere with the vaccine working if they were administered close in time.
All right, sorry.
I was just going to say, and I think if you're fully vaccinated and you're not otherwise immunosuppressed, you really would not be a candidate for getting the monoclonal antibody as well.
Yep. All right, Jill, last question.
Bob wants to know, if Dr. Hawkins is now Hawk, does that make you Honeycutt or Hot Lips?
Wait, do I get to vote here?
Yes.
Yes.
It makes me Spock. Is that okay? Come on, stick to the right theme here, people. All right, folks, let's see what our final thoughts are for today as we wrap up the program a little bit. First, Dr. Poland, thank you, by the way, again for being with us. It is a delight to have you on this program.
It's a privilege to actually work with both of you as colleagues. We're all pulling together here, trying to solve this problem. Let me just say that right now, an American dies every 60 seconds of COVID. That need not be. For those of you that are hesitant, who say, I don't know who to listen to, go to any academic medical center's website and you will see reliable information there. Politicians and celebrities are not reliable individuals in terms of dispensing medical advice. Go to the experts.
Thank you. Hawk.
Yeah, I just want to say I appreciate when Dr. Poland is on. So helpful. Thank you. I know for our viewers, you make very difficult topics easy to understand, so thank you very much. And I would totally agree with that. I'm seeing a patient in the hospital now, early 50s, otherwise healthy, does a lot of activities, but went from needing a little bit of oxygen support to needing much more oxygen support in a face mask. And just asked, why didn't you get the vaccine? Because it was too new. And when I said, well, all of this could have been prevented, it was just like a blank stare. So these are very preventable things. The vaccines still work. Get fully vaccinated, get those 2 doses, and it will significantly protect you from having to come to the hospital, from getting into the ICU, and even dying. So.
Hey, thank you guys both for being with us. And we're back tomorrow with Dr. Brian Holmes, a good old family doc from Abilene, Kansas. Mm-hmm. He describes the pushback he's seeing in the community over vaccination and mask mandates. That's tomorrow morning at 8. We'll see you then. Before we go, though, don't play all the music. I want to make my final comment. We have said all along on this program that we're going to tell the truth. We're not going to be flapjacking, meaning we're not going to flap our arms and jack with the truth. Because what we want you to realize is that the gospel we've tried to preach the entire time of faith, hope, and science is what keeps you safe. Faith in each other and faith in the medical profession and science to try and help you deliver the answer. Hope that we will get to that answer, and then the science which can bring us home. Faith, hope, and science is the combination that we need. But that works only under 2 conditions. A, you wear your mask, and B, you get vaccinated, and C, we can all stay safe. All of us can stay safe if we play it like that. That's the final answer. And tomorrow, we'll talk about being back in that freezer again. Thank you all very much. We're back with you tomorrow.
Thank you so much for joining us this morning for this Best of Morning Medical Update. You can catch our live broadcasts every Monday, Wednesday, and Friday. And don't forget, you can always email us at medicalnewsnetwork@kumc.edu or reach out to us on Facebook, Twitter, and YouTube. We will be back to our live shows 5 days a week starting September 6th. So please go out, make it a great day.